Welcome to the Imaging Symposium. Again, I would like to echo Dr. Kenny's remarks for thanking Toshiba, Siemens, and Philips for sponsoring this event. And I'll hand the microphone to Damien, who will introduce the speakers.
Thank you, Dr. Jazzy. So there's been a little change in the program. I hope you'll all enjoy this. I think it was something that we felt strongly about. I think this technology is evolving, and as you saw from the live cases today, either most labs are if they haven't established it already, are in the process of evolving into more advanced forms of fluoroscopic imaging. And I'd like to again echo Dr. Jazzy's thoughts and just welcome you all to this advanced fluoroscopic image and infusing modalities session for congenital and structural interventions. There's been a slight change in the program. I think Dr. Lee Benson is going to speak first in the Siemens rotation, and then Rob Dowie will speak later on at the last session. So maybe I'd like to invite Dr. Lee Benson to come up, who's well known to all of us and always provides a very entertaining and erudite talk on anything he takes on. So he's going to talk to us about 3D angiography and cath lab workflow in congenital heart disease. Thanks, Dr. Benson.
Thanks very much. Thank you very much. So it's a pleasure to address you this evening about our experiences with 3D rotational angiography. I'm on the Siemens advisory board. That's my disclosure. So as an outline for what I thought I would talk to you about is how 3D rotational angiography can improve case workflow. And as a paradigm for that, I chose coarctation of the aorta stenting. And we'll talk to you about how, what the procedure steps are that 3D can help with. And then I thought I would touch upon some anatomic things that you can learn from three-dimensional acquisition to understand surgical anatomy and change, perhaps, the way the surgeons do an operation based on demonstration of relationships that you can't see by two-dimensional angiography. And then finally, in Toronto, we have some advanced applications of the data sets that are acquired from the 3D rotation, and I just thought I would show you some of the images that and some of the projects that we're working on which can expand your armamentarium of interventional and anatomic understanding. So 3D volume rendered images give you CT quality imaging. This is actually from Munich. John Hess, they were looking at the relationship of the balloon to the coronary arteries in preparation for a melody valve implantation. So it improves your spatial understanding, and it also improves your anatomic understanding and anatomical outcomes in terms of surgery. This is a hybrid patient who's gone through stage 2, as you can see with the Glenn. In our institution, we retain the ductal stent. It's a modification of the procedure that Chris Calderon defined, and we look at the way the stent in the left pulmonary artery, and the stents in the aorta, mind you, the left pulmonary artery interact, and I'll show you some images of how more information we can get from three-dimensional acquisition. And then finally, you've all seen images like this of how the acquisition will allow you to better define, particularly in the pulmonary arteries, where you might have to do an intervention. So it does impact the way we approach the patients. So the first thing we wanted to talk about is workflow, and we've incorporated three-dimensional acquisition in the catheter lab with a focus to reduce the procedure time, to improve the anatomic assessment, and contribute to better planning of the intervention. And as I mentioned, I'm going to use coarctation of the aorta as a paradigm for that strategy. So I think all of us do coarctation stenting differently. There's no, this is the way to do it, but in general, the standard anatomic study that we perform is biplane angiography in 30-degree caudal, 20-degree LAO projection with a left lateral. We then repeat the angiography in order to get the best angulation to profile the image and the landing zone. We measure the lesion from the angiogram. We do the stent implantation, and then we repeat the biplane angiography to make sure that the wall is intact and there's been no disruption. So those are the steps we'd use for standard protocols. By incorporating a three-dimensional acquisition into the anatomic assessment, the way we do it is to perform the 3D acquisition first. We then rotate the image until we find the projection that is ideal in order to identify the lesion and the landing zone. Right now, we're repeating the angiogram in single plane because 3D acquisition does not give you systole and diastole. It gives you an average, and we're still a little concerned about precise measurements. What you measure on the 3D is what you measure, but it's not systole or diastole. So we repeat the angiogram. I'll show you an example of that. And then we perform the implant with a dynamic overlay. And I think Carlos this morning showed a stent implantation where he had acquired the image, and he was able to overlay it into live fluoroscopy, which is a very useful technology that you can use with this kind of acquisition. And then you may or may not repeat the 3D study, depending on, we're doing a research study, so we do the 3D acquisition, but you can repeat do biplane again to examine the wall of the vessel. So just as a technical note, because and all the systems are a little bit different. Carlos mentioned the way he does it's 30 frames a second. You do a 5-second rotation with a 1-second delay, so the injector begins the injection for a second before the rotation, so it's 6 seconds of total acquisition, 5 seconds of acquisition, but 6 seconds of injection. We do a breath hold, our patients are anesthetized, and we pace the RV for coarctations, 180, 200 beats per minute. We use 300, IsoView 300, so the iodine content of our solution is a little bit different perhaps than what you use. You have to sort of factor that in when you play with defining what you're using for your acquisition, because it's a dilutional, it's not full contrast. So we give about a cc per kilo. We dilute it 1:1 or 1:2, sometimes even 1:3, depending on what we're looking at in the pulmonary arteries. So a 35-kilogram child would get 35 cc's of contrast, a 2:1 dilution. It's 105 cc's that has to be injected in 5 seconds. So that would be 126 cc's in 21 seconds. So that's what we would get. This is a typical image, patient that came in the laboratory for coarctation, stenting. We would then identify the ideal projection that we would believe would give us the best information for the implantation. We would then do a single plane in this projection in order to make our measurements in systole. So we can pick the stent length and the stent diameter that we would ideally implant. And this is the final image. We don't repeat biplane angiography. We just do a Dyna-CT. But again, this is a research study. So this is the kind of information you can get. Very, very sophisticated application of understanding the topology of where the head and neck vessels are, where the stenosis is, and very nice information about what you've actually accomplished with the stent and whether the stent is involving other vessels that you should be aware of. So it's very good information. But I mean, the goal here is to change the workflow to streamline the procedure. So we've done a little comparison study, not very scientific, mind you, because it wasn't done prospectively, but nonetheless, we compared 10 patients that we acquired the procedure with the Dyna CT and 10 without. The procedure times were the same, so it didn't lengthen it. The median fluoroscopy time was obviously less with the Dyna CT, and the overall radiation exposure was not significantly different, although because the ranges of the DAP and the air karma were very, very wide for both groups. But so the overall radiation exposure with one Dyna CT acquisition was comparable to standard multiple biplane acquisitions. So that's sort of like the workflow issue I wanted to talk to you about, but I just want to mention some things that you can also do with these kinds of three-dimensional acquisitions, and that's to understand relationships. This is a young child who's had bilateral stents. In fact, this stent over here on the right PA, which you'll see on the rotation right over here, was actually fractured, and you can actually identify right here where the fracture is. So it's very well detailed information to help plan how you're going to intervene on these patients. Other examples, this is a patient with left pulmonary artery stenosis after a bidirectional Glenn. And what we were interested in, of course, is why this patient had left pulmonary artery stenosis, and you can segment the imaging, so you can, for me, you have to use different colors because I'm not that good, but you can actually see that the left pulmonary artery is related, in this case, to the left pulmonary artery stenosis, in this case, is related to the left bronchus, which is being compressed and causing the stenosis, and that helps understand whether balloon angioplasty, what kinds of stents could you put in order to treat this particular kind of lesion. This is another child with very similar problem, except he has a retained stent after a hybrid stage 2, and you can see here's the retained stent, and you can see the details of the anatomy. Again, if you're interested in feeding back to your surgeons things about what they're doing in the operating room and demonstrating to them what the three-dimensional relationships are, this is an excellent way of doing it. And these are just two still pictures of another child with a retained stent and how it relates to the left pulmonary artery. I don't know if you can see this well. This is looking from the back. Here's the stent. This is the left PA, and here's the trachea coming down. So it's a very complex three-dimensional arrangement that this kind of technology allows you to visualize and learn about. You learn a lot of things that you never understand with two-dimensional imaging. So we also use the data set for other things, and I just wanted to show you some examples of resurfacing, overlay, segmentation, modeling, and then fluid dynamics. You can take the data set and you can reconstruct it and you can resurface the image so that you can get better information about diameters and dimensions and an understanding of how these things are oriented as you try to understand what you're actually doing. When you overlay, usually you can then overlay and understand how, for example, this patient who had an aneurysm, who was stented, how the aneurysm is interacting with the stent structures. And because when you get the acquisition, the registry is exactly the same because the patient doesn't move. You can either overlay like this, or you can overlay like that, so you can get an idea of the changes in topology for some of the procedures you're doing. Again, this is just an example of stenting. And of course, we're always very interested in how the stents relate to other structures, so you can segment the images. This is the stent and the catheter through it. That's the trachea, obviously. So you can put them together and you can get an idea of how the stent relates to the bronchus, or you can use different segmenting algorithms and see how these three-dimensional structures or what you're actually doing three-dimensionally to the patient's anatomy. We're interested in stents and what happens to the orientation of the aorta when you put a stent in. So you can use mathematical modeling with centerline acquisition. So this is the absolute center of the vessel. So you can see how there's changing orientation before and after you do a stent. These are all done for mathematical modeling after the procedure, so something you can learn about what we're doing. And then finally, we have the facility in Toronto to do models. We can make three-dimensional models with a machine, but you can take the data set from the data acquisition from your Dyna-CT or your three-dimensional rotational angiogram, and you can make a model. And this is just a model that we made of a radiolucent silicon of a patient who we're planning on doing a intervention. You can actually make it so it's radiolucent, and you can actually do the procedure and see how things are going to change with an angioplasty alone in this particular patient. And then finally, the last picture is that you can take the data sets and then you can reconstruct them and actually do computational fluid dynamics, which is also something very interesting in the pulmonary circulation and in the aorta. So you can learn about what happens before and after stents, for example, and different type of arch constructions. So with that, I just leave you to say that three-dimensional acquisition is not just a pretty picture. Thank you very much. Okay. All right.
So we have some time if there's any comments or questions from the audience.
Lee, those beautiful pictures. The reconstructions that you did that included things other than the vasculature, so when you had the lungs and the trachea, how long does that, we're doing reconstruction of just the vasculature, and that's pretty quick.
Yeah.
But to be able to include everything else seems like that's probably pretty time consuming. I'm just curious how long that takes.
It really doesn't take very long. Our radiology techs, actually, I was hoping that somebody would ask that question, because I think we should have a competition, and we should have them timed, the radiology techs, for reconstructing the images, because it takes them about 2 minutes in order to get the vasculature, and it doesn't take them much. It takes them a long time because the group that work with me, they're very sweet and they're very smart, but they're colorblind. So everything is the same color, and I can't figure out which is the trachea and which is the lungs. So that's the only big issue, but it's very quick. It's actually very fast.
Dr. Wilson? Oh, sorry, yeah, Dr. Bass.
I'm sorry, thank you, John Bass. So I just wondered about you said you were doing pacing, and I was wondering what that did to your fluid dynamics.
Well, no, for the pacing study, we only do that for the acquisition before the stenting. You know, but when you do, we haven't done. It's a good question. We haven't done the project for just acquisition and fluid dynamics. Obviously, it's going to affect it when you pace it, because it slows down the stroke volume, it reduces the stroke volume significantly.
Lee, thank you very much. I'm very humbled. And as an old boss of mine used to say, Neil, you have a lot to be humble about. But I'm going to give you a hard time now, because you said on one of the early slides that reducing procedure time was one of your aims, and you didn't. But you did demonstrate a reduction in fluoroscopy time. So what is taking the time? If your fluoro time's down, your doses are better, but your procedure times are the same, what's taking the time?
These original patients were the beginning of the learning curve, and we have 2 different rooms. The new acquisition, we have a Siemens system, and the Artist Z, which is what we have. All right. Okay, we have 2 different systems, and one system takes a little bit longer than the other. So that accounts for the discrepancy in the procedural times.
Okay.
Lee, those were beautiful pictures. The fluid dynamics, I'm interested in that. Now, is that, you're not actually collecting fluid volume flow with this sort of a system, that you're you're calculating that later, saying if the cardiac output is this
Yes,
is what...
you put the boundary conditions in later.
Yeah, and is that something that comes with any of the manufacturer's things, or that's a
No.
proprietary?
Well, I believe that the companies do have those kinds of packages that you can acquire, but what we're using is something that a commercially available computer system.
All right, thank you.
Dr. Fagan?
Yeah, Lee, especially when you're talking about the relationship of vasculature to airway, does the system allow you to actually get into the multiplanar reformat, since these are all CT-like algorithms? Because that's what we've actually been using, and that comes up instantaneously, where we actually just cut through basically its CT slices to look at airway relationship to vasculature, that sort of thing.
Mm-hmm. Yes, it does. This system does the same thing. It gives you CT quality images that you can do segmentation on.
Great. And Dr. Miro, just one last comment?
Yeah, great images, everybody agrees. You still do another angio before deploying or choosing your stent, so you can compare the diameters and the length. What's the average difference between your diastolic diameter of a 3D reconstruction and the systolic of your 2D? I imagine your 2D, you told that you were not doing pacing, of course. For your second acquisition, your confirmation acquisition, you don't use pacing, of course. Okay, so what's the difference?
Well, there's about there could be up to a 20% change in the diameters in a coarc before and after. I mean, it's not, but up to. So you can have a 2 or 3 millimeter now within the error of measurements.
So you would say you would probably continue doing this angio to be more comfortable about choosing your stent.
Yeah, comfort's really important. Yeah.
Especially for the patient.
Well, I mean, Neil is worried about procedure time. If the stent embolizes, then it's a long day. Yeah. Mm.
Great. Thanks
Okay,
again,
thanks.
Dr. Benson. That was
Thanks very
fantastic. Okay, so again, I'm very fortunate there's no real introduction needed for any of these fantastic speakers we have. This is Dr. John Cheetham, who's going to talk in the Toshiba part of the section on new innovative equipment designed to advance imaging and reduce radiation exposure and effective use of 3D ORA in a cardiac or conventional surgical table. That's a fairly long title, but we're looking forward to it. Dr. Cheetham, thank you.
As a matter of fact, it was a title given to me, and it's so long that it's not fitting on the screen completely. So will the rest of the slides not be quite on, guys? Or is there no guys to do this? Yeah, I can see it's off to the, so I'm not sure what will or won't show. So anyway, it is a long title. It actually hurt during the links and everything. Again, for disclosure, I'm a consultant for a non-paid consultant for Toshiba Medical Systems, and I just wanted to. Oh, there you go. That's better. Just talk very quickly about physician-industry relationship as we go through this. I mean, it's certainly very important, I think, that both parties, physicians and industry, talk about improvement, patients for our care and for the care of the patients and new technology, and we keep that in mind. Certainly, over 17 years, I've had a close relationship with the people in Japan and in California. One of the reasons, actually, it was because when we talked to their engineers about things for congenital heart-focused improvements, they actually listened, and so there was a lot of dialogue. And one of the things that happened was that the CEOs were very insistent that the voice of the customer was important, so they would always send their biomedical engineers to the procedure room, and they'd stay for a week or so, see what we actually did, what their equipment did, and the improvements that we were asking for. And then, of course, you still, I think, have to be honest with yourself when you start assessing new technology, new equipment, that you have to always do what's right, and of course there are reasons for that. So what we started with, and since we're going to talk about a little bit about equipment design and technology as well, is we kind of, when we had the engineers come over initially, we were thinking about hybrid labs for the first time a long time ago. You can see the little drawings. Well, what would be if we had this cath lab equipped in a cath configuration? What are all the equipment if we had the cath lab in an OR configuration, so we could figure out how to design the equipment? We ended up with something like this. And you can see that one of the things we talked to the engineers a lot about was, we're all used to biplane labs, and typically biplane labs were the best and newest AP position, or just thrown in with a lateral tube, not with the idea of ergonomics of what are the cases that we do during these procedures for congenital heart disease. So with that in mind, we had the engineers come over. We said, look, we need equipment to not just be a lateral thrown in with the frontal plane. The ergonomics of the lab have to be such that we can do procedures that are very complex and still have access to tiny patients and big patients, etc. And so this current system was designed and implemented in 2005. And then one of the other things about the equipment that we like, because as you know, when we get in complex biplane angles, sometimes one plane's okay and the other plane's not. So the variable isocenter was very important, since we can move it up and down and adjust the cameras accordingly. And then one of the things that we quickly recognized after we got this beautiful equipment in the hybrid cath suites was it was not perfect for the surgeons. It was perfect in the sense that all their equipment, everything could be placed very nicely, but it wasn't perfect from a table standpoint, and we'll get back to that in a little bit later, because they couldn't, as you know, the standard cath table is integrated into the imaging system, but not as an OR table. So when we started on the hybrid OR suite, we said, okay, who's going to pick the equipment for the x-ray equipment, and the interventional cardiologist, and of course the cardiac surgeon needs to pick the table. And so we ended up with a McKay surgical table in our first hybrid OR suite, but that brought challenges as you would think. The McKay table is a terrific surgical table. It has great multifunctionality, and you can see all the crazy things that it does. But that means that when you're going to have your imaging system somehow integrated or talk to it, it's going to have to understand a whole new different set of ranges, etc. And some of the people from TMSC went over with McKay and talked about, well, how's the table, what are the issues, so they could try to integrate the X-ray equipment as good as possible without it being manufactured by the same people. And so you can see this is the Magnus table that we have currently in our hybrid OR. It has lots of great different kind of movements. And this is currently the hybrid OR suite. The imaging equipment is ceiling mounted. It parks completely out of the way, so it looks like a standard OR when you first come in. But then, as you can see, the equipment, we drive it in so it stays out of everybody's way. It's not floor mounted, but ceiling mounted, and then does all of the complex angles that you want it to do the procedures. And then, of course, we centered all of our suites together. And then what we really did in the hybrid OR to start with was we started exploring exit angiography. And it was a little bit of a challenge, and you can see why I'll show you some films here at the end. But we get back to our hybrid cath lab, and we kept saying, well, the table still is a problem. So we took this idea, and we went to the engineers with the input from the cardiothoracic surgery and the interventional team, and said, we need the table to do certain things for the surgeons. We also found out that if the table actually cradled and tilted, that just like an OR table, that we could actually get more complex angles as well. So what we came up with ultimately was a cradle table, and you can see that it actually holds more weight than the standard table, and the 16 degrees tilt and cradle that it does in complex angles. And you can see either in a single plane or a biplane room. And so it became a very nice thing for our team, but also when the surgical team comes in, and we'll kind of go through that. And what we use now in the hybrid cath suite, not just for hybrid procedures, but also, as I said, from complex angles, and everybody is now used to the table and all of the movements, etc. So it's actually quite nice in the cath lab. One of the things that the surgical teams would say is, but sometimes it's too narrow at the top, so you can see there's a top widener and surgical adapter where you can adapt surgical instruments, because as you know in the OR, there's the halo and all the other things that go on, so that's really not an issue anymore as well. There are some advances, as you know. I mean, we predominantly went with 8-inch panels for a primary congenital heart. They now have the 12 by 12, and probably if I would do this again, I'd have an 8-inch and a 12 by 12 panel. And of course, our system of the monitors, now there's the larger 56-inch monitor, and then you can, of course, move things over in the monitor. And I saw here at the meeting that actually there's a 90-inch monitor now as well, and you can do up to 24 inputs, etc. Now you saw in our hybrid room, we actually put auxiliary monitors that rotated around, so we didn't have to put all the multifunction things right on this, but this is very nice if you're starting to build a lab now. Well, one of the things that we really were talking to the company about is attempting to try to reduce radiation dose management. And all the companies, very important. It's important to us. It's important to our patients. It's important to pretty much everyone at this time. As you know, this is one of the big topics. And so we said, well, since we got flat panel detectors, went away from image intensifier, is there some way that we can continue to have excellent imaging, but at the same time reduce the dose? And one, quote, not simple way, but one way to do it, instead of doing digital acquisition, could we in fact be doing fluororecord? So our fluoroscopy was the same image quality as a digital acquisition. And so what they came up with was what they call SNRF, or Advanced Imaging Processing, or Super Noise Reduction Filter. So you can see the spinning wheels. This is the way the engineers test. And you can see over to the left the signal noise, the super noise filter on and then off, and then the recursive. And you'll see a blurring. And one of the reasons is because the no lag time now. So it's kind of a one frame to one frame when you have the super noise reduction filter on. And as I said, this is part of what they call advanced imaging processing. And so you can see that, so with this on, what we found was that we could just step on fluoro and then do fluororecord instead of digital acquisition. So these are two images representative. These are coronary images from one of the adult labs. You can see the coronary stents and the fine guide wire. One of them's fluororecord and one of them's digital acquisition. And it turns out you can see there's not a lot of difference, and certainly from a standpoint of being in the lab and doing your procedure, there's not really any difference. This is one of the new Texas Liberty, and you can see again fluoro and digital acquisition are very, very similar. And you can see some of the coronary work here with the same thing. Some of the guys in runoff lesions, this is again this is fluororecord rather than digital acquisition through peripheral vascular stenting. This was a patient that just after we had this installed in about a year and a half, 2 years ago, and you can see that this is an image of a patient that's going to get a melody with digital acquisition and fluoroscopic record. And the image quality was excellent, and we do most of our images on fluororecord now, most of our recording. This is a patient Ralph just did, and you can see this is under AIP or fluororecord, and that's a still frame. So it's very, very it's an excellent way, and you reduce the radiation dose at the same time. And you can see the helix frame still under fluororecord very easily in a melody valve implant. So that was one of the things that we asked the engineers to do. They did a great job. So we said, well, how does this influence now what's happened with our patient as we've tracked them over the various changes? So obviously we know the reason why we need to do this and monitor with our pediatric patients because they keep getting exposure. We know the harmful effects of radiation. And also, we, at our institution, when we first went there, they wanted to know what the time of fluoroscopy was, and that was what Radiation Safety Committee looked at, and we tried to explain to them it's not the time that you have the fluoroscope on or acquisition. It's more of the dose, and we know about air karma as the DIP, just like Lee already mentioned. And those are obviously, since no one really measures exactly skin dose, as you know, we calculate that. So this is, for instance, in our lab now, we put together a radiation protocol that we've done now over a long period of time. We have our team manage this data. It's updated all the time. And then we have follow-up protocols, patients called, et cetera, and it's based on the patient dose. And we divide them into tier 1, 2, and 3. And you can see back in 2008, that in fact where we were and some of the things, the fluoral frame rates decreased, the acquisition frame rates decreased, and then we started using AIP back in the third quarter of 2010, and we continued to drop the dose and drop the number of patients that are in a higher radiation dose despite very long procedures because we're almost always on fluororecord during these procedures. This is a new technology. It's called spot fluoroscopy. And we do not have this to this date. This, as you can see from last image hold, you want your region of interest, and then you can from that last frame hold, you can draw a box or a frame for the area that you'd like to see, and the only thing that you're looking at when you're stepping on the fluoro is that area, whereas the last image hold leaves you with the same, as long as you don't move the camera and everything. And you can pan this around to look at various areas of interest, so you're really only taking fluoro in one specific area. This is something we're very interested in. It's a dose tracking system. It was recently awarded Most Innovative at RSNA in 2012 when it was introduced. And you can see it's actually it's live, up-to-date imaging of the various areas. Is this moving around? There we go. And so we like this, particularly some of our large patients, that we could use this on, because we would then start changing camera angles as we watched if a certain area of the skin is getting more radiation than we'd like, and we then move that around. So we think this is going to be a big advantage. Now I'm just going to quickly, because I'm going to lead into 3D rotational angiography, going into the OR suite, and Evan's going to talk a lot about 3D rotational angiography, and we'll also talk about some of the things Lee did. This is easy to do, obviously. It's all integrated into the system, because this table, all the cameras are integrated together. But we're also going to have to do this in the OR. But one of the only times that we always do digital acquisition is in 3D rotational angiography, because that's the only mode that it's set for. You have to do digital acquisition. We've given a charge to the engineers. We want to try it in fluoro record and not digital acquisition, so we can really knock the dose down during that time. And Lee already talked about the dose compared to the conventional biplane angiography. And so we had the team, first of all, just come out and say, what can we do to the system as it is to try to continue to reduce dose during the 3D rotation? And you can see some of the things, the engineers, they come out and do lots of fancy things, and you can see they say, okay, well, if we do these are the ways we can change. We can do the input dose from the FPD, we can do the beam filter, change the diameter, and et cetera. And here are your dose reduction for each thing that we may do, and here's the disadvantages of doing each one. And then after they went through all of this, where we are now, and they said, here's what we think would work, still give you image quality, and yet still reduce the dose. They reset everything. They tested some phantoms, which you see here. Is this good enough? Is this 0.5 millimeter? Here's what it looks like when you do this lower dose 1, lower dose 2, lower dose 3, and then you start to say, well, that's not, I don't like that because I can't tell the image well enough. So you take somewhere in between. And so we ended up doing that after they did all their phantom testing, and then they reset our 3D rotational system to where the new, which is in the yellow, you can see that they offered an L1 at 110 centimeters off, and L2 a lower dose. And so we then now have that as a menu. So as you click through your 3D rotation, you then keep clicking, and then you just, if you want to do a lower dose, you can do the spin under a lower dose, either 1 or 2, and reduce the radiation dose. And right now, it's about 33% lower dose if we just go to our L1 setting than the conventional setting for digital 3D rotational. And if you do L2, it's 50% lower. So as we took this knowledge and trying to reduce the dose, we said, well, what are the challenges when we go into the OR in a McKay table that doesn't talk to this system? So it's a lot more work. You can see this is during on bypass, how the spin goes. You have to be sure that it's not going to hit anything, it's not going to hit the floor, it's not going to hit the pump, it's not going to hit the anesthesiologist. But in the end, in our exit angiograms, as Lee's already pointed out, we get much more information from that single angiogram. And then if in fact we need to do an intervention, just like Lee said, we go to the angle exactly that we need to go, and we treat them at that point in time. It's not always easy if you look at Iman or anesthesiologists, because in the OR they don't give themselves long tubes like they do in the cath lab, so they've got to be pretty nimble in there. And you can see from the different angles, and again, it almost swipes the floor, so you can't have anything on the floor. And then looks at one more view here. And from the other side, you'll see guys kind of getting out of the way. But again, the perfusion machine's out of the way and everything else. But this is just a patient that, Ralph, we just did this last week. It's a little 3-week-old that just had aortic arch reconstruction. And again, very similar to what Lee showed, you can see lots of different images that will help you make decisions. And also, then the same thing that Lee showed you, all of the other things you can see in there, whether it's the trachea and the lungs and everything else, we of course cut that out for this one. And like Lee said, it's more than just a pretty face, but this is prettier than his little sunset or whatever that mountain picture was. So this is actually the volume when the 3Ds first come out. They're actually a cylinder of volume. And there are also some other really advanced applications, as you can see, both from that the neuro guys use, and you can see carotid and overlays, et cetera. So I think that, certainly we're very, very lucky, I think, to work together. We're ultimately, we not just want to have the fanciest toys, but at the same time we have to have some output from this, and that needs to be improvement in our outcomes for our patients, but also at the same time lowering radiation dose. Thank you.
Maybe time for one comment question, if there's anybody. Dr. Walsh.
John, why when they do the 3D rotational, do you have to X-ray the whole baby?
Why is the picture so big? Like everybody's, by the way. Yeah.
They're all the same.
Yeah. Well, there's there's two settings on this. There's 110 and 120. The SID goes, because when you hit the button, everything goes out, the lateral goes out, the APN, the table goes up, down, and boom, that's what it is. Part of it is related to the arc, the C arc, and the angle, the table. The companies try to make sure, because our spin's in 4.1 seconds instead of 5. And regardless, if it hits something, it hits it too fast, so you can't have it hit anything. So part of it is table width. Part of it is they want to be sure, because there may be a big patient on there too. So it depends on the ergonomics of that. I've asked the same question because I said, how about if I don't, and it always goes to the 8-inch, by the way, too. It goes to 8-inch. I said, well, maybe I don't want it on 8-inch. Why do I want to do that? Why can't I? So we're working on that, so it's not so easy for the companies to do that, so that's why we're saying, why don't you look at AIP fluororecord and do a spin on fluororecord and see if you can get the same quality image.
I imagine you could just be putting shutters, and for small babies, you don't need, like he says, to irradiate his arms and everything.
It disables if you change the height, if you put in, won't go. When you step on it, because it automatic, when you step, there's the delay, like Lee said, injection starts right before the spin, won't go. It may be programmed, and maybe the engineers here can say, oh, we can change that, but they haven't so far.
Let me just comment on that. So, because we've done a fair amount of small babies, you can collimate, just like you say. So you can collimate, if you think about the way this works, just from a simple, we're not engineers, or I'm not making. So as it rotates around the axis of the body, you can certainly collimate top to bottom. And that actually does save you dose. We looked at that. It doesn't degrade image quality. What you can't do is collimate side to side, because as you're coming through your sweep, you'll be cutting off and you'll be having.
Because that's what you're looking at. You're seeing the table on the outside. Yeah, we tried to do the side to side, Evan, and it said no go, because we didn't want the whole table and everything. But we'll start doing top to bottom if that works.
One last quick comment.
Yeah.
So I'm just wondering about your lab personnel, because we've come to the point of usually disconnecting the vent, or at least having the extension tubing on, and getting everybody back, because I'm making the assumption that the scatter dose is a lot higher during this rotation, because you're hitting a lot of stuff that you normally wouldn't
Yeah,
hit.
it's higher for the rotation, as Lee already showed, yeah.
So,
you mean as far as just personnel and getting everybody?
Yeah, because you have your anesthesiologist sort of right in the middle of the spin. Are they, how are they dealing with that?
Evan's going to show, maybe he's going to show his film, and their anesthesiologists go in a couple of rooms away. They actually leave the room. And we kind of leave that. We have not unhooked them and people walk out and leave them alone. You could do that. You could hook them away and walk out and stuff, but that's, if they ask to do that. But right now, our anesthesia guys are used to just staying there. But no, you're correct. That's a valid point, and one that I probably won't tell them.
Great. Thanks again, Dr. Chu. Fantastic. So now I'd like to invite up to the stage Dr. Thomas Fagan from Denver, who's done some fantastic live case for us last year and is going to do some more again for us this year to speak on behalf of Philips on 3D CTM or overlay technologies and their use in congenital heart disease cases. Thanks very much.
Thank you, Damien and Ziad, for the invitation. So this talk may seem a little short because initially we're dividing this up into 3 segments for this 40-minute period, but Elkin, I guess, is going to be at the end of the program now, is that correct?
If he makes it, he's
If he makes it,
somewhere
yeah.
in transit.
Yeah, so a disclaimer is, yes, we have grant support, hardware, software for our systems in our lab provided by Philips. So obviously, as you've heard already from the other speakers, the goals of three-dimensional road mapping, you've heard a lot about 3D RA, but also including here for CT and MR, several different things. One is to improve the confidence and efficiency of intervention, reduce the overall radiation dose, which you've heard quite a bit about here already, reduce contrast dose potentially, and also reduce our procedural times. All of which would be good, and I'm not going to pretend that we've got data here that says that these modalities do it, because we're very new in our experience, but that's what I'm going to walk you through now is the experience we've had at the University of Colorado. So initial prototypes that we had initially started at the University of Colorado Hospital, John Carroll's lab. The system was an XCT format. However, in February, then the newer prototype became available to us, which was called Heart Navigator, and that was available at both of our institutions, University of Colorado and at Children's Hospital. How the system works initially, the segmentation process, you take three-dimensional data sets from CT or MR, and you actually import them into the Heart Navigator system. Here you can see the standard, see if it'll show up. So we've got the axial, the coronal, and sagittal images. Here what you're seeing is an auto segmentation process where here you see the right ventricle and pulmonary, a conduit to pulmonary artery. This system actually picked this up on its own since it's a CT scan. It's very good for that and designed for it. MR is a little more difficult. Usually we have to do a lot of manual segmentation. If you look at the image here, this three-dimensional image, watch here the right pulmonary artery. As we move to this image and we start to here, you can actually manually segment the segments of this three-dimensional data set. We'll come up here to the right pulmonary artery and start to fill this in more. And if you watch up here in this segment, you'll see the right pulmonary artery continue to grow. Again, with our MR data sets, we have to do a lot more manual segmentation process than we do with CT. If we didn't like it, we can undo it. There's erase modes. There's all sorts of different ways that you actually reconstruct this image. A lot of this is done by myself or the other physicians. My imaging docs do a fair amount of it, Dr. Brian Fonseca. But this is the type of image that you can get when you finish. And that's the segmentation process to define the anatomy. The next process is actually then to register this with your system. And different than you've heard already about the three-dimensional rotational angiography, where all of those images are acquired by that system, and it understands the spatial relationship in between the detector and the camera. Here you have to actually import the images and tell it where it actually lives. And we do that here with the Philips system by using for the most part, we've used the trachea to help register our images. And we do it also with a 2-view spot fluoro. So we'll actually rotate the camera to 30-degree RAO, then 30-degree LAO. And I don't have, I have to apologize, don't have images to show you of this process. But by segmenting in the trachea as well as the cardiac anatomy, here you can see the trachea, we rotate 30 degrees and actually move the image to overlay right over the trachea. So hopefully you can imagine that process. Hopefully we can show you that to you on Tuesday as well. But then once we register it, then it understands the gantry position, table position, just like you've seen for the 3D RA. Here you see the surface rendering, but a lot of the work we've done, we've actually removed that and just gone to an outline form here, so that way you actually see a bit more clearly the angiograms right behind the whole image. As you saw that outline form, as they crossed each other, it does change colors a little bit, and I'll show that on a couple of different slides here. So here's that same example, and this was used for stent placement in this conduit prior to transcatheter pulmonary valve. So again, you see the surface rendering, the three-dimensional images on the far left, the right ventricle pulmonary conduit to the pulmonary arteries, outline form with the documenting here a hand contrast injection showing the registration and anatomy, and seems to be pretty dead on for this patient's anatomy. And then we use that for just positioning our stents and stent delivery, as you can see on the frame on the far right. Now the slides are a bit more complex, but is also, again, CT imaging. This is a 41-year-old patient that had, all 4 of her pulmonary veins became extremely stenotic after atrial fibrillation ablation. The CT images that we obtained, we used to segment here the right upper pulmonary vein. For the most part, we did the right lower as well, but what I'm going to demonstrate here in the next frames, here you can see the red outline This is actually the right upper pulmonary vein after transeptal approach and catheter wire position. Again, it gets a little confusing with her pacemaker leads and TE probe. And again, here the airway is outlined in green, but where it crosses the vasculature, it turns yellow. So it's a little complicated, but the area of interest was right here where that right pulmonary stenosis is. Hopefully that shows up well enough for everybody. Again, the frame on the far right shows stent delivery across the area. This shows MR imaging. This is a very complex coarctation, very tortuous transverse arch. This patient had undergone a 22 millimeter jump graft from the ascending to the descending aorta. You can see after the segmentation process, we can rotate it around like you've seen for the 3D RA images to try to get the best projection. As you see at the tail end of this, this movie clip, when we were actually using this to actually find the best angiographic projections we could try to get to not only see origin and ending point of this conduit, but also really find where that stenosis was in the conduit graft for stent placement. Notice this true arch is sitting right up above the conduit graft when we got to that final position, and I'll come back to that here in a second. So the overlay image, again, we use the outline form, but if you watch with the contrast angiogram, the outline form is actually a fair amount larger here than what the conduit was. And that's because with this technology, anyhow, with the same structure, if you have two overlying portions of that structure, you don't get delineation to it. So the head, the true arch was overlying this. So what we did was actually get back out of the system for a second, resegmented out the true transverse arch, and then the anatomy and the alignment were actually very close to what we were used for stent delivery. And that's shown here with showing unsheathing of the stent across this extremely kinked portion of this conduit, and then stent delivery on the right panel. Final angiogram, so good apposition in both proximal distal parts. There's a bit here in the very more anterior portion of this conduit where the stent's not in apposition, but the stent was in proper position and opening the graft as much as we needed it to. So here I'm just going to step through briefly our experience so far, and this is an IRB approved and monitored study. We're looking at this specifically. We've got 100 patients that we plan to enroll in this, and for both CT and MR overlay. What we're planning to do is compare our procedural results with that of patient-matched historic controls. In the assessment, first off, there's a primary operator rating of the utility, and that's basically compared to having just fixed plane angiography by itself, so fairly subjective, admittedly. We'll look at radiation exposure and contrast dose and procedure time. Our results so far for MR overlays, we've had 9 patients. This started in February of this year when we've got the newer prototype. The majority of our cases, at least 5 of them, were related to coarctations or that the extreme coarctation patient that we just showed the examples of. As you can tell, as we rated this, we had our rating was either inferior, no advantage to fixed plane angiography, or superior. There is a learning curve to this and using the process, and as you can tell, it took us a little bit in the beginning to get used to the process. And the main reason for the sort of no advantage ratings in our first couple of patients we did was a little bit basically just because of the time involved in trying to register this, the images. But as we got more facile with that, the rest of them in the registration process become much more facile, where you can tell, and as far as the technology goes, these 2 patients, a little bit later in our experience actually have nothing to do with the technology. It has more to do with what happened during our procedure. This patient that we were going to perform a coarctation stent on ended up coughing and moving on the table right at the, getting ready to deliver the stent. And at that point, we decided it was, with the time involved, everything else, even though it wasn't much, we just decided to deliver the stent. But the utility of it, again, based on that situation, fell into the, not superior category. And our next one actually ended up being pretty complex pulmonary arterial disease, and it was actually more of an issue of the quality of the images that we got from an outside institution, which we thought fairly well represented pretty proximal stenosis of the branch pulmonary arteries. As it turned out, we had fairly discrete and multifocal distal stenosis, which wasn't picked up on the MR based on the type of acquisition done. And I guess, using MR imaging like this, you can get overlay of the pulmonary veins and pulmonary arteries, and that wasn't picked up on the MR prior to this, so they basically blurred together. So based on that, we decided, since we had to do multiple interventions in distal veins, that wasn't picked up on the MR. The overall rating was no advantage, but it had nothing to do with the technology. It was more on the acquisition of the MR up front. Our CT experience is actually longer than that for the MR. The majority of these are all pulmonary arterial work, with the exception of the pulmonary vein patient, which was our very last. With this, though, we had the first prototype wasn't part of our grading scale, and a little hard to go back and get that same information. So for the most part, we left that out. And again, we see that as we move through this, we actually felt a bit more comfortable corresponding with our experience with the MR data sets as well. Some of the challenges that we found already with this, again, I already mentioned our registration process. I think we can actually do a little bit better job with this. So I think, we're looking at different ways to do this. We've had several patients where we actually used fiducial markers. What these are stickers that can go onto the patient's skin. These are done on patients that come in for an MRI procedure cath on the same day. So that way we can place these on the skin where we feel they'd be in a good place for the MR and also out of the way for fluoroscopy. And initially they get a vitamin E capsule, which shows up under MR quite well. And then when they come to the cath lab, they pop this little bead out and put a radiopaque marker in it. And then using that for registration here, you can see these green circles are where the fiducial markers were placed. And they were segmented in as green. But here there's a patient with severe pulmonary valve stenosis that had still hypoplasia of his RV and needed a glenanastomosis, but this is just showing the potential for overlay and registration for using these fiducial markers. But again, I think we have a little bit of work still to do with our registration process. Another downside to all of these images, and from what we've seen so far, three-dimensional rotational angiography as well as these type of images, they're not real time. So if you acquire the images and then later do something like we've done here, which is to put a stiff system through the aortic arch, here again with the overlying structures of the trachea, you get a little bit thrown off here with the color, but the aortic arch is traveling in this orientation here. But you can see after the stiff wire goes into position for this stent delivery, it distorts the anatomy a bit, and at that point, anatomy is not going to line up as well as what you had before. And this may be an overall limitation that may not be able to be corrected initially with this type of imaging. Just to let you folks know, as we move through this then, Heart Navigator is FDA approved at this point, and it is have indication for both structural and congenital indications. And its main indication is for TAVI work, and it's for CT, and that's what it's supported for right now. MR and 3D, which we've got the capability of performing in our lab, is still a prototype, but the long-term plan is to have this as they move forward, is to have Heart Navigator as the system to use. EP Navigator was designed for electrophysiology work, especially imaging the left atrium for atrial fibrillation ablations. Right now that does have the capability somewhat of providing all three modalities of CT, MR, and 3D RA type of imaging for overlay. In conclusions from this, then, I believe anyhow there's at least tremendous potential for these 3D image guidance modalities in congenital heart disease. However, as you can see, there's still significant work that needs to be done. These or newer modalities of 3D guidance will become part of basic catheterization lab imaging in the near future. Lots of folks to thank with this, but primarily I would like to thank Dr. John Carroll for introducing me to these type of this work that he had been doing, and introducing me to the folks in Phillips that we were able to move this toward congenital heart disease. Thank you very much.
That was great, Tom. Thanks so much. It was fantastic, and it's great to see how you guys are pushing the boundaries with the other folk who've been talking here today. So we're very honoured to have you, Dr. Wilson.
Hi, Tom. There's a lot to concentrate on there. Regarding the outline registration, if that's the right word for it, you showed a picture where the outline was way off and then one where it was accurate. Can you just go through what was the difference?
The last one I talked about it not being real time?
No, you showed images early on of outline measurements, and there were red lines drawn around the supposed contours of the aorta.
Yes.
And one, the outline was way off. It was much wider, much greater dimensions.
Yes.
And then was, let's say, accurate. What
What
was the artifact there?
The difference here is that using the outline mode here, if we had done it differently and actually used a surface rendering, like the initial MR image of that arch and the complex graft, That shows up a little better to show the difference between the conduit and also in that projection, you actually got portion of the transverse arch which was still in view. With the outline form, those two merge together so you don't see that differential line between conduit graft and the true transverse arch. Are you able to follow that without an image to point to? So both of those two structures were overlying each other. If you had a surface rendering, you could see them both, but that line differentiating them in an outline form disappears in this type of technology. So instead of switching to a surface rendering, like a lot of the images I showed you in the CT initially for the conduit, the outline form, we went through it, desegmented the transverse arch that we weren't going to stent and just removed it completely. I can go back to that slide if it makes it more
Well, no, I think I understand, but then does that not make that aspect of it a bit clumsy? I mean, I'm looking for an easy way out. You know, you dilate, I don't know, a stent, a pulmonary artery, or a coarctation, or a vein, and you want to say it was 3 millimeters before, now it's 9.6. Do you use the image outline for those that sort of quantification or not?
No. No, we don't use this to actually try to quantify how, you know, either prior vessel size or how we end up. Those would be a standard angiogram to produce those. One, for reasons mentioned, most of these, as I understand it, and again, I'm an interventionalist, not an imager, but I think these are all averaged images as far as the CT and the MR goes, and some of these are not gated. So we're not measuring those in systole versus diastole. So the same issues that Lee brought up can be at play here, as well as a window leveling problem when you actually take, you know, some of these images and you actually, you know, change some of their dimensions and characteristics that way. You can change their diameter just by the process of the post-processing of it.
We should probably move on if you guys are okay with that. Thanks again. That was fantastic. It gives me great pleasure to introduce next Dr. John Carroll. Dr. John Carroll is Professor of Medicine at the University of Colorado and Director of the Interventional Cardiology and the Medical Director of the Cardiac and Vascular Center, again at the University of Colorado. I think he's been a real innovator and worked very closely with the congenital group there and has really helped to translate some of the advances in adult cardiology along into the congenital and structural group. So he's going to speak about echo and X-ray integration, a new modality, and we're very honored to have him. Thank you.
Thank you, and good evening. This is a great symposium, great idea, and hopefully something we can build upon, because imaging technologies, image guidance is becoming such an integral part of when we have new devices available, how we use them. And what more fundamental imaging modality than echocardiography is important for adult congenital heart, and all other forms of structural heart disease. Echo just plays such a key role. We've had over 10 years relationship with Philips, starting with the X-ray division, going to the CT and the ultrasound divisions, and they've had an on-site imaging scientist during most of this time, and that's really helped us get to know each other and develop new approaches to problems that are real clinical issues. And one of them is of course, 3D echocardiography, which really has transformed things. If you just think of how rapidly it's become disseminated within a short period of time, it's almost like a new device in terms of its rapid acquisition. And that's because it is so intuitive, it is so useful, and it has been heretofore not really integrated into the procedure room where we used it. It was primarily developed as a diagnostic modality, but we as interventionalists, of course, have special uses for images. And it provides us with images that really make us think of, hey, that used to be a textbook idealized image, and then now these images are routine, that we see structures like an ASD in the degree of detail that has been shown in the past in terms of medical images. Secondly, we see images of devices with anatomy. So inherently different from X-ray imaging of a variety of different interventions where we see very well the device because it was optimized for fluoroscopic imaging, but now we can see both the soft tissue and the device itself with 3D. And we have had very clear anecdotal but broadly agreeable changes in the complexity of interventions because of the challenges really more of image guidance, and MitraClip really is the prototype around the world of a complex intervention that's become easier because of better imaging. That allows us to see, to align in 3D space, something that we had to constantly move a TE probe around, had to integrate in our minds 2D slice images. So interventional echocardiography has two major technology components, 3D TE and ICE technology, and it's come along. But there are certain issues that remain. Number one, we've all seen the variability of image quality, and we're used to, in these presentations, seeing the best, selective best. Secondly, we know the way echocardiographers have really evolved in the last 5 years to embrace this major new frontier, and some have made that transition, some have not. We certainly have seen that the traditional views of a structure that are mainly diagnostically derived may not be the best for performing a task, and that we have to visualize more than anatomy, but it's wires and catheters, and sometimes ultrasound's good, sometimes it's not so good. And certainly there hasn't been integration heretofore of ultrasound. And when you think about a lot of these procedures that should be predominantly ultrasound guided and obviously reducing radiation dose profoundly, how would you redesign the procedure room for a predominantly ultrasound guided intervention? And that X-ray still is fundamental. How do we integrate? So imaging guidance is different from diagnostic imaging in that it's very focused. It's very much, you select the right modality for the task you're going to perform and what sort of acquisition mode and what kind of display you want. And finally, real time. As Tom pointed out, we are interventionalists, and doing things in real time is key. Structures are constantly changing, and we need that. So designing a dedicated structural heart disease comes with a couple of questions we want to work with manufacturers to answer. How can we better integrate it such that it's not the cumbersome roll in, roll out, plug in, plug out? How can we at the table side have some control over these key images that we're interacting with? And how do we get clinically useful combinations of the two such that we get visual concordance rather than kind of looking at the same structure from a couple different perspectives? Can we in fact have some efficiency by combining the two? And can we actually start placing images, labels, such that we can our whole team can know what we're doing, can identify structures as we turn these complex 3D data sets where we know where a certain landmark is and don't get lost in 3D. So combining these two in this development project we've been doing with Philips for the last few years is registration. And I even don't have a slide of registration because it is so easy. It's 2 fluoro images of the TE probe, and that is all that's needed. And now the 3D data set from the echo is registered with the X-ray. And as you see here, you start producing echo images that are concordant with X-ray. Like here we're going to do a transeptal puncture. Here's the typical view, soft tissue, and you can see slight changes of the gantry. Again, ultrasound images now labeled in gantry orientation. That's how major of a change this is. So we have this old transeptal catheter image, but we really don't know where the soft tissue is. Now we do. Now we can place precise targets of where we want, whether we're doing MitraClip, left atrial appendage, AFib ablation, and ultrasound can obviously be presented in both 3D modes and the 2D, so we can have all the power of different modes, different display options with ultrasound. And we can no longer be confined to just having one view. This is a mitral valve, a St. Jude valve. 2 devices are in for paravalvular leaks. We've got a third one to go. We want to see it from the ventricular side. We want to see it from all views. And so we get both of these, and we get side views, which diagnostically an echocardiographer would never really present to you because it's really a view that's determined by wanting to get a side view of where you're going to cross. Very unique. And where you place a particular mark will now show up on fluoroscopy because the two are registered. So you make fluoroscopy have the key landmark soft tissue target that you want. So it becomes smart fluoroscopy. Then on the table side, you have a mouse, so you can do a variety of different interactions with the image. You can move it, you can enlarge it, you can rotate it, and so here's the intra-atrial septum, here's a transseptal catheter, and you realize now when you start interacting with these images, when we do procedures, we hardly cross in textbook fashion. We're often angulated. We're actually trapped inside a PFO tunnel with this transseptal catheter, something that I live to regret doing a mitral valvuloplasty where I couldn't maneuver. But you can see these images so well, and you can manipulate them at the table side. The echocardiographer puts the TE down, finds the optimal position, and it stays there. That's where it's landed. That's where it's left for the majority of the intervention. And you can continue to quickly interrogate device anatomy relationships. Now we have a third vascular plug in here. This is the target that we had put in to help place it. You can see the target represented in the fluoroscopic image. And at the table side, you can rotate this freely to rapidly and easily see. And you can start thinking about creating optimal views for navigation that heretofore were not under your control. You know, you had to communicate with the echocardiographer, but often it was more difficult to communicate exactly what you wanted. And here we had a side view of a mitral valve, and we wanted to crop it. And this is a view where it's cropped away. So you see this orifice of a mitral stenosis patient. We've cropped away this blocking component of the 3D ultrasound digital data set. So we've created a unique 3D TE valve view that is concordant with an REO fluoroscopy view, so it really makes it much easier to cross a stenotic valve. And this is the way in fluoroscopy where you see the 3D echo data set and how it's going to be projected on the X-ray image. And so you can place a marker, you can use that, you can place labels. These are labels. Very important when we're talking about, as John did, hybrid rooms where you've got a lot of people in the room and half the people know what you're doing and half the people don't know what the heck you're looking at, what you're seeing. And you can put labels on it and show them and keep everyone on board, and that really helps the whole team stay on board. So, more efficiency. I mean, we want just not good images, but we want to be able to do specific tasks that used to take a lot of time quicker. And that means, yes, if you're using fluoroscopy at all, less radiation, but it obviously has a lot of other advantages for performing maneuvers. And then you can immediately cross, and you see here we've got a catheter across a paravalvular leak. You can see it from multiple different angles, and you can kind of immediately have very clinical, useful insights. I've crossed, I'm outside the valve ring, I don't have to wait for the echocardiographer to give me a different view to figure that out. I'm in the right spot, it's where I put the mark of the third remaining paravalvular leak, and I know the trajectory is a bit such that when I pull back from the LV side, the vascular plug, I may grab on that, bileaflet, portion of the bileaflet valve, and I've got to be careful of that. And I'm excited to just see this out there in your hands, because I think we'll all learn new things of how to perform a variety of different interventions more efficiently, with more insight into what we're doing, how we'll use these things like landmarks, how we'll use these things like labels. I think it's very exciting. These are tools being put in your hands. And you have the ability to do something very quickly. Like here we put an ASD in, and you used to ask the echocardiographer, okay, take a look and figure out whether we've captured all the tissue. Well, you're able to do that at tableside by scrolling right through the ASD device, and you can see all the tissue capture. And so really, under your control, within a minute, you answer that final question, you release the device, you're done. And so that really enhances the workflow. And I think we all respect the echocardiographer's time. They come in, they dedicate a lot of time, and in some systems it's very hard for them to do that. So in conclusions, this integrated echo X-ray guidance system has specific features that have been developed in response to what we need. We need tableside control. We need cropping that allows us to see structures buried within a 3D data set that normally wouldn't be revealed. We need the ability to harmonize X-ray and X-ray 3D images. We need simultaneous perspectives. We need the ability to place labels, landmarks. And now the role and the added value are being documented both in terms of an obvious better understanding of anatomy and the 3D relationship of deployed devices and defect, and wouldn't that be useful in understanding issues like potential for erosion? More efficient navigation. You know, we're navigating in 3D open space in a lot of these, and using a 2D imaging modality, be it fluoroscopy or 2D echo, is passé. And it really allows us to communicate better with these team-based procedures, and that is a key enhancement. Thank you.
That was great talk. Thanks so much, Dr. Carr. Maybe in the interest of time, what we'll do is, because we're never sure if Dr. Bruckheimer is going to charge in on a white steed any minute, what we might do is maybe continue on with the next talk, and then we will have some time at the end for questions, if that's okay. But your enthusiasm for the technology is very, very evident, and it's very exciting. So it gives you great pleasure. Now, what we'll do is, as I said, we're just a little bit behind time, depending on whether Dr. Bruckheimer makes it or not. So what we'll do is we'll just move to the next speaker. On behalf of Toshiba, I'd like to invite Dr. Evan Zahn to the podium to speak to us. Dr. Zahn needs no introduction. He's been a huge proponent of 3D rotational angiography and advanced imaging and has published widely on it. And he's going to speak to us, as I said, on behalf of Toshiba on new insights learned from 3D rotational angiography. Is it worth it? Thank you.
Thanks, Damien, and thanks to Damien and Ziad for holding this symposium. We had a conversation, Ziad and I, a couple of years ago, about wouldn't it be nice to sort of just focus on imaging, and I'm glad to see that it sort of progressed to this. There's a lot going on, and I really want to compliment the other speakers. I've learned a lot, and there's a lot of good stuff out there. Everything I show you will be from our Infinix Toshiba system that we used and continue to use in Miami, but I am not a consultant for Toshiba. Just real quick, and just to put this maybe into some perspective, for the better part of 60 years, I think it's fair to say that 2D angio has really been the mainstay of cath lab imaging, and that, let's not forget, there are numerous good things about two-dimensional angiography. It's quick, and it's easy, and there's virtually no setup. It's time-tested with some great textbooks. This is my personal favorite, for reasons many people understand, written by Bob Freedom. It gives us dynamic information. Dynamic information allows us to look at systole and diastole. It allows us to look at how our devices interact with each other in real time, much like Dr. Carroll was just showing so nicely with echo. It allows us to look at important events like extravasation, which you would not see particularly well on static images. And there's been methods devised, albeit imperfect, to quantify from two-dimensional angiography that are time-tested and well accepted. But 2D angiography, as you've heard over and over again tonight, has some limitations, the most obvious of which is that we have been viewing complex three-dimensional structures in 2 dimensions. And fairly extensive knowledge, lots of years of training, lots of reading is required to get the proper relationship between your camera and the structure, and even then, you're still kind of guessing as to where to take the best picture or the best view. Multiple injections and projections are typically required for complex structures like pulmonary artery stenoses. There's significant interference with PA and lateral flat panel detectors with not just one another, but with the patient and the operators and the anesthesiologists and everybody else, which limits you, and perhaps that limitation is having us miss some diagnoses. Okay? We get limited or no information, as you've heard so nicely tonight, about surrounding structures, and I think we have a very limited and simplistic way of looking at how our interventions do after we perform them. Finally, quantitative measurements, they can be done, but they're based on some, I think we could all agree, less than perfect calibration schemes which have been developed by necessity over the years. Okay? Finally, the additive effects of multiple angiograms cannot be underestimated in terms of radiation dose, especially on growing patients' children. Okay? 3D angiography, as you've heard tonight, has at least the potential to offer some new insights and some new additions to some of these issues. Okay? There are some important theoretical, at least, advantages to 3D RA. Complex three-dimensional structures can finally be seen in 3 dimensions, as you've seen so nicely. Extensive knowledge of course, angulations, relationships really isn't required, because with a simple picture, you can eliminate the guesswork of what your optimal angle is. Okay? A single injection in many cases provides complete anatomic information on a given structure, albeit static information. Views are no longer limited by hardware or people in the room or the patient themselves. Okay? You can virtually get imaging from an infinite vantage points. Surrounding structures, as we've seen so nicely demonstrated, are now visible, and reliable measurements, measurements that aren't based on how good you are at tracing a catheter, can now be made. Calibration is virtually eliminated with this technology. And I think 3D perhaps doesn't get enough credit for the ability it's going to give us to evaluate our interventions, particularly stent interventions, after we perform them. Okay? And there is, as you've heard from several of the speakers tonight, there is at least the potential to reduce radiation exposure with these procedures, and I hope to actually show you some real-life data, limited, at the end of this presentation. Okay? But there are important disadvantages, or at least learning curve, as you've heard from 3D RA. It takes time to set it up, so as John alluded to, this is a video I like to show. The guy in black is our anesthesiologist. He is turning off the ventilator. You can see, for whoever was asking, how far are people away from the patient? Far. There is scatter with this. The flat panel detector is way off the patient. He is literally leaving the room. We're good with that. They do it all the time. It's either that or playing a lot of solitaire, so we're okay with that. Patient's fine. Rapid pacing going on. 5-second acquisition being made. Okay, so there's a process to all this that takes coordination with your colleagues. You saw how John had to show you can't have anything on the floor, and so on and so forth. We do manipulate physiology to get the images I'm going to show you. We reduce cardiac output. We limit respiration. Those may have disadvantages we haven't even thought of. Although the dye volume is really quite acceptable, the fluid volume is significant, and as we all know, kids tolerate that pretty well. Most kids, but I'm sure if we do this long enough, we'll find some patients where that turns into an issue. Radiation exposure was a big question when this came out, and I think we're getting better at answering it, but we need to acknowledge it. The images, if you heard, are static, which has clear disadvantages over dynamic images. And although post-processing, I would agree with Dr. Benson, is an under 2-minute proposition, it's 2 minutes we didn't have to spend before. So the question becomes, and the rest of this talk will deal with this question, is obvious. Is it worth it? Okay. First, let's get some definitions. Commonly utilized images with 3D RA are not just the beautiful rotations, right? There's the unprocessed rotational angiogram, the three-dimensional reconstruction, and what I like to call the tomographic slices. So this is the unprocessed rotational angiogram. It's immediately available. I actually find this quite useful. Okay. There's the 3D surface rendered reconstruction. You've seen a lot of this tonight. Available in about 30 seconds or less on most workstations. This took about 60 seconds of post-processing. There's really not much to it. I don't have the text do it. I do it myself tableside with a mouse. It can't be that hard if I'm doing it. It allows for virtually views from almost any angle. And then there are the CT-like cuts, which I believe at this point I get the most usage out of and the most bang for my buck. These are CT-like cuts. You can really have an infinite amount of cuts that you can make. You can look at things en face for the first time. I think that's pretty important. And there's a whole lot of software that goes along with this that lets you do lots of neat things, which I'll show you through some cases. So I've shown this case before, but I think it's so illustrative. I think it's worth looking at. 13-year-old patient of mine with a Fontan, question of an LPA stenosis, looked pretty good on the AP, looks pretty good on the lateral. Okay, but doesn't look so good when we look at it from her head to her feet. It looks like she might have an important stenosis. Okay, turns out that stenosis is undiagnosable, okay, on just 2D angiography because we can't get that view. Turns out it's important. It was symptomatic. It was treated, and she gained some benefit from that. So how many diagnoses have we been missing by limiting our imaging to two-dimensional angiography? Well, Darren Berman and our group in Miami, when I was there, published this just recently, this past November. And what Darren did was he looked at a group of consecutive patients with single ventricle palliation that we did 3D RA on. Not a huge group. It was 28 patients with Fontans and Glens. But importantly, what he found was out of those 28 patients, 19 of them, or nearly 70%, had 22 lesions that we judged we gained additional information from rotational angiography. Well, was it important information? We thought it was, including this group of 13, where the intervention was performed solely on the basis of the information we gained from 3D RA. So much like that patient I showed you where we would have never stented that angiogram, that left pulmonary artery appearance, we felt in these patients it was important. Most of those patients receive LPA stents, just like you saw with lesions similar to the ones you saw. Okay? As Dr. Benson said, I think we're gaining a tremendous amount of understanding of the mechanism of things. You know, we're so used to seeing just an indentation and treating it, but all indentations, it turns out, are not the same, and we're starting to see lesions that we haven't really appreciated, or at least we didn't in Miami before this. So this is an LPA that doesn't look too bad. There's a little notch on it on one of the caudal projections, but when you look at that with rotational angiography and you turn that around, it looks like there's clearly a ribbon or torsion stenosis of this vessel. And when you take the CT cuts of that and you can thin them out, you can clearly see that this vessel's been twisted. Well, what's the significance of that? Well, one, it's real good follow-up for our surgical colleagues. Two, I see that now, and I don't think angioplasty has any role here in treating this because I can't figure out how an angioplasty would straighten out a torsion, so that patient goes right to stenting. Okay? Another example, similar but different concept. We've all seen this. After a bidirectional cable pulmonary anastomosis, a stenosis to the left and the right in the bottom of the glen, and we say, boy, what did the surgeon do? That doesn't look like a hard suture line. How did he get that stenosis just to the left of the glen? And you can see this patient's also had a stent in place, but that doesn't seem like that's the problem with that stenosis. Well, as we begin to look at this, and we kept seeing this over and over again, this is a patient who had a Norwood palliation, we kept seeing what appeared to be the PA stump being flipped up. It's just flipped up. And we had an extensive conversation with our surgeons about, boy, we think we're seeing this a lot because isn't there a way to tack that down? Again, it's something we can't appreciate as well on 2D or at all, but we think this will change the way that our surgeons complete this operation once they've ligated the pulmonary artery. We believe that 3D RA is giving us ability to improve our decision making by evaluating some of these complex structures. So a little girl with a very complex aortic arch reconstruction, sort of a single arch into her head and neck vessels, and what amounts to a very important stenosis just proximal to where everything comes off. So she came to the lab, and you know, we've sort of made a whole lifestyle out of stenting kids like this, little babies who have complex problems, and let's put a stent in and fix it. But this one kind of spooked me, and when I saw the 3D RA, I was real worried about how this particular lesion interacted with the native tiny ascending aorta, which acts as basically a single coronary for her, and that single takeoff of her 3D head and neck vessels. And using the technology afforded to us, not just changing views now Now there's software, and this is just one example, of where you can take these images and you can sort of drive through them, or picture a pane of glass where you can sort of eliminate as you go through. So in this case, we took away half the image and drove through it from the front and from the side. And with this kind of evaluation, again, real time at the table side, what I concluded, for better or for worse, is that putting a stent in this position would have been a pretty bad idea. I was worried about what I'd do to that single coronary. I was worried about the head and neck vessel, and I was worried about the stability of the stent. And this was a lesion I probably would have treated, but sent her to the operating room to get that arch reconstructed, based on that kind of decision making. We can't overemphasize that we think it's pretty important to be able to improve our decision making by looking at the relationship between structures. So we've started to do simultaneous injections. This is a patient who had an arterial switch many years ago and has somewhat complex supravalve pulmonary artery stenosis. Again, we all treat this differently, but one of the ways we like to treat this is with bilateral proximal PA stents. But we looked at this 3D RA, and I began to be concerned not only what impact that would have on the ascending aorta, but also on the coronary arteries, which filled, and particularly the right coronary artery under that right pulmonary artery. And as you've heard tonight, segmenting, making packets of images, you're able to take away and subtract things. And I was just not comfortable after speaking to the surgeons about the proximity of the right coronary artery and what I would be doing to this ascending aorta. And again, it's another patient that I think historically I would have went in and tried to do a complex intervention that I felt was better served not doing that intervention. Again, relationships between structures and what effect is our interventions going to have. So what looks like a diffusely hypoplastic left pulmonary artery after a Fontan turns out is a fairly bad stenosis when you look at it from head to toe. Okay, that's not window and leveling. Okay, that is the true diameter of this teenager's vessel. Okay, but not only is there an issue with that, there's an issue between where this vessel lies. This LPA is somewhat caught in a vice between a dilated aorta and the left bronchus, which you can see posterior to it. And I can tell you, we had a lot of trepidation about this, but I don't want to just show you cases I backed out of. So we did go ahead and stent this, and we were real worried about this LPA being compressed, or what effect would this have on the aorta. Well, we ended up getting a nice angiographic result, but you can see a few things. The flattening of that aorta posteriorly. I don't know what effect that's going to have. It certainly makes me think maybe a little more about erosion. We didn't have any effect on the left mainstem bronchus, but I think the point of showing this case is at least we're seeing these things. I mean, these are things that were left to our imagination before until the patient came back and had collapse of the left lung because of left mainstem compression. This technology, more than being a pretty picture, gives us now the ability to look at these relationships virtually real time by ourselves in the lab without having to go down to radiology. Okay. This ability to obtain these unlimited orthogonal planes and measure in them without the errors introduced with calibration, I think is gigantic. And I have virtually gone to this for measurements where I don't think that dynamic measuring is as important. And again, being able to measure a stent result in 360 degrees with en-face assessment, that's just not something we do very well with two-dimensional angiography. So a little data, just a little, to go with this. There's been a lot of talk about can you trust the measurements, so we decided to look at this, and again, this is from Darren's paper. Looking at right and left pulmonary artery measurements, we looked at a whole bunch of things in single ventricle physiology where we know pulsatility is not an issue, and we know that these patients probably have less difference in dynamic vessel size than other patients, and we saw what you can see the R values are excellent correlation between two-dimensional measurements and three-dimensional measurements. What this tells me is not that 3D RA is good, it tells me that two-dimensional measurements aren't as bad as I thought they were. Just looking to the future a little bit, where are we going with our interventions? You'll hear great talks at this meeting, and soon we'll be seeing centers like Toronto and Columbus putting in new types of valves in the right ventricular outflow tract that treat a whole bunch of patients with much more complex anatomy than conduits or bioprosthetic valves. How are we going to evaluate patients like this for the newer generation of valves that come out? Well, I think our evaluation has to be a lot more sophisticated than an AP and a lateral angiogram. And this kind of technology, I think, will provide that to us. As you all know, right ventricular outflow tract morphology after surgery is almost infinite. This is just a sampling of kids we did in a short period of time just to emphasize how different these can be. But with this type of imaging and the accuracy, if we can overcome the dynamic issues with the imaging, we're going to want to be able to get measurements of this type of sophistication before we say that a patient like this can have a product like this. Right? We're going to have to start thinking a lot more in complex relationships and in 3 dimensions. So we've started to look at this right before I left Miami, and the group continues to work on this. These are now measurements all along the right ventricular outflow tract, both length measurements, diameter measurements, relationship measurements of both the outflow tract and the branch pulmonary arteries, diastole, systole, what correlates to 3D-RA, because as was mentioned, the measurements we get from 3D are really averages. But it turns out it still may be useful even in its current state for certain things like length, which will be a pretty important measurement when we start looking at the new generations of valves. It looks like the R value for lengths of RVOT, distances from branch pulmonary arteries, are going to be pretty good. And to our surprise, these are now tetralogy patients with pulmonary insufficiency. It turns out that at least in this relatively small sampling, that the R value for things like the RPA, this is RPA diameter, LPA diameter, were not nearly as scattered and bad as we thought they would be. So we'll see where that leads us. You've seen from Tom and the group at Colorado has really led the way with this beautiful image fusion and overlay, and I think all the systems have this capability to one degree or another, and I can't help but think how nice it'll be to start working with 3-dimensional overlay images. This is rotational angiography. We've seen it with CT and MR, and I agree with Tom that work needs to be done on this, but there's little doubt in my mind that as we begin to work over 3D images, especially these more and more complex interventions, that's going to offer us some advantage, or more importantly, our patients some advantage. Okay. Finally, just my concluding remarks are about dose. We've heard a little bit about dose tonight. John showed some nice work that the Toshiba engineers did with reducing dose. This is just a graphic representation of what the 3D-RA system was giving out in terms of CT dose before it was tweaked, and you can see how nicely that, and I think this is true for all the systems, dose can be managed and brought down. But perhaps this is the most compelling argument I've seen, and I really appreciate the guys at Le Bonheur Children's lent me this data. This is unpublished data for an abstract that they've submitted and are presenting at the ACC, so I certainly don't want to give too much detail. It's their hard work, and I don't want to give it away, but they were good enough to send me the summary. And what their summary showed, this is over 135 patients, split roughly in half, 2D versus 3D, looking at radiation dose. And what they found was that individual acquisition dose was actually lower for 3D. Contrast in their series was higher for 3D than it was for 2D, and I think that's probably true for most of us, but still certainly less than 2 cc's per kilo, which is not an unheard of dose. Contrast per case, if you look at the total volume of contrast received per case, was equal. Exposures per case was actually less for the 3D patients. These patients, I should say, were matched for age, size, and diagnosis. Entrance dose was about equal. Area dose was about equal. Cine acquisitions was significantly less for 3D patients, because like we've been sort of supposing, if you get one 3D and then use simpler imaging like hand shots and fluoroscopy like John showed, you can actually significantly probably reduce cine acquisitions. This is the first time I've seen somebody looking at this prospectively in a comparative trial. Acquisition frames, less for 3D, and overall fluoro times for the cases, less for 3D. So I think this is remarkably important work. It's the first example I've seen of people looking at this prospectively with age-matched controls. So in conclusion, I would say that 3D-RA is really, as you can see from the other presenters, exciting new technology that certainly warrants at the very least further exploration and application. There are numerous complementary advantages to what we standard 2D imaging and echo and everything else we have in the lab. I think that the early concerns, when I gave these kind of talks a few years ago, early concerns regarding image quality and moving structures, radiation dosed and contrast load, for the most part, these have been and continue to be addressed. Not that we're done, but it clearly has been shown that we can work within these confines. And finally, I would say that 3D-RA offers important benefits to the care of congenital heart patients, and when available, should be mastered and incorporated into the care of our patients. And people need to stop being a little intimidated by the prep work and learning curve and really take the time to learn this technology, because I think it really offers a lot for the people we take care of. Thanks for your attention.
Thanks, Evan. That was fantastic, as always, and I'm sold.